This conference will now be recorded.
Well, good evening and welcome to AnCan's Low and Intermediate Risk Prostate Cancer meeting for Monday, July 27th, 2026. And welcome to all of our ongoing friends and new guests. And Bill Franklin and myself, Stuart Jordan, will be sort of tag teaming our way through this evening with assistance from our founder, Rick Davis. We would like to note that this is a peer-to-peer support group and nothing that we say should be construed as medical advice. We are here to share our collective experience and answer questions and hope to educate you to take information back to your team to discuss with your doctor or doctors. Before we begin, we always like to thank our sponsors that sponsor all of our prostate cancer virtual support groups. They are Novartis, Telex, Blue Earth Diagnostics, and Foundation Medicine. Bill, do I have that right?
That is correct.
Okay.
Currently, hopefully we'll
Currently.
bring some more on board here shortly.
And we'll just mention that for those of you who are not familiar, we have multiple prostate cancer groups that address different phases of. We have an active surveillance group that meets on Wednesday nights for those considering or have opted to postpone or avoid treatment. In tonight's group for low and intermediate, we're talking to people who have had or are planning treatment. And please know that we do not discuss recurrence in this group and instead invite those folks to join the high risk recurrent and advanced prostate cancer group that will meet tomorrow night. We also have special groups for veterans, men under 60, gay and bi men, and a group for European men. So we invite you to participate wherever makes sense for you. And I think that's all of the housekeeping. Bill, did I miss anything?
I don't think so.
Okay. So the way, Jeff, you'll be up first. We always like to talk to our new participants up front. And we have a couple of questions that we'll start to ask you just for us to get up to speed on your situation and then see what we can do to answer any questions that you have.
Very well.
So Jeff, your last name, please.
Gandolfo.
Okay. And if you have not signed up for notices, for reminder notices from us, if you want to put, well, you can't put your email in the chat box. If you can send us an email when you have a moment, we can get you on the list. And when it's
Okay.
Bill is B Franklin.
You can actually, it's easy, just send it to info@ancan.org. And I'll get that also.
Okay. So Jeff, how old are you?
I'm 67.
67. Okay. And where do you live?
Connecticut.
What part? I'm in Wilton, Connecticut.
Oh, okay. I'm in Westbrook. I'm in the other end of the state.
Okay. And by any chance, are you a veteran?
No.
Okay. And how did you hear about us?
Through the nurse navigator at Mid-State Medical Center, Karen Stavris. She's an oncology nurse navigator.
I'm sorry, what was the name of the I got the nurse navigator part of, but I blanked on
What was the facility name?
Karen Stavros.
No, the facility.
Oh, I'm sorry, Hartford Healthcare?
Oh, okay. Okay. So, Jeff, when were you first
Yes.
diagnosed?
April of this year, April 26th.
Okay. And what prompted the diagnosis? How did it come about?
I went in for an exam with my doctor, and he did a rectal exam, felt something, and said, we need to do a biopsy, and then from there we did the PSMA PET
Okay.
CT scan.
Do you have any history of PSA? Do you know what your PSA is or was?
It's the most recent one was 2.03.
Okay. And while we're on this, do you have any family history of prostate cancer?
No,
Brothers or father or grandfather?
no.
Okay.
So Jeff, I just want to clarify. So he recommended a biopsy solely based on a digital rectal exam?
It was yes, he felt something there that was a little funny. Nodule.
Okay. Have you had an MRI to look
Yes.
at the area?
Yes.
And
It
the
revealed a 29 cc gland with no suspicious prostate lesions, EPE or lymphodectomopathy, or whatever.
So your MRI was completely clear.
MRI, and then PSA PET scan revealed no significant avidity.
Well, so you had a PSMA PET scan also. Okay.
Yes.
Were both of the MRI and the PSMA before biopsy?
No, after.
So they went DR, you had the exam, then they did a biopsy, and then they sent you for an MRI and a PSMA.
Correct.
Okay.
So it was not a MRI fusion guided biopsy, I'm assuming, since the MRI was after the biopsy.
Yes.
So, and was it a transrectal biopsy or a transperineal?
Rectal.
So what were the results of that biopsy?
On the biopsy, 5 out of the 12 samples revealed cancer, and with this, the GG2 at the RLA, RB, and GG3 at the RLM, RM, and RLB, and plus one of them had a cribiform gland.
Okay. Do you have the Gleason scores?
The Gleason was 4+3 on 3 of them for 7, and the others were 3+4, or 3+3, I should say.
Just do you know how many 3+3s there were?
Let
Well,
me get
actually,
to
I
that
guess it would be
here.
2 of them because you said 5 and 12.
Yep, there were 5.
Oh,
Yes.
Okay. And you're saying that they noted cribiform on one of them.
One of
By
them, yes.
Okay. By chance, did they indicate whether it was large or small cribiform?
Says cribiform, poorly formed glands, percentage of pattern, tumor measurement. How, I'm not sure.
Okay.
It just gives an estimated percentage of prostatic tissue involved by tumor for core.
Okay.
No pernervial invasion was not identified. And my PET scan said there's no spread. It's still confined within the prostate.
Okay. I'm going to guess the answer is no, but have you had your biopsy slides sent for a second opinion?
And yes, we just did that last
Okay.
week.
And what did you do? Who did
And
you send them to?
I believe they're going to Yale, New Haven.
Okay. And you don't have
No, they
those
said it would probably
results yet.
take, no, they probably said it would take 2 weeks.
Okay, we always advise that you get a second opinion. We, as a general rule, would recommend, we have a couple of expert doctors that we recommend. In this case, since you've got them going to Yale, New Haven, our comment would be to see, well, let's see what they say, and then could have a discussion about whether you think there's a reason for you to go to Dr. Epstien or a couple of the other people to get a read. The important thing will be to get a clean read on that crib reform, and
Okay.
as well as to get agreement or disagreement on those 4+3s, because that grade would have a major impact on treatment decisions.
Mm-hmm. And they also were sending for Decipher, genomic testing.
Yep. So they're sending that out.
Yes.
Okay. Did they talk about having any form of genetic testing, germline testing, which is to identify whether you have inherited any mutations or have any genetic indications that would also impact your um, your treatment plan?
No, they did not.
Okay. That's a very simple either blood test or saliva test that can help identify if there's anything really of concern. So that's something. Now, didn't ask the question. So who is treating you at this point?
Well, I saw originally urologist was Dr. Paul Pio at Midstate, and then the first instinct was to see a surgeon, which I went to see Dr. Chang at Tallwood, which is part of Hartford Healthcare, and discussed the surgical implications and possibilities and what to do. Went over that with him, and then thinking about it, I said, well, let me talk to an oncologist as well, radiation oncologist, whom I met with last week, and just to get a feel of what way he thought, where I should go and whatever.
So what kind of recommendations
And
are you getting from these guys?
well, the surgeon was very open. He said, you need to look at everything and explore all the opportunities. And I appreciated that. He explained everything, what happens and all that. And the MRI, he said, was also very good for him because it helps him with the surgery. The radiation oncologist, he was really pushing for radiation. And one of the comments made, he said, well, you have surgery, you don't know what's after the cut, you don't know what's on the other side of the knife. And that didn't sit well with me. I think he was pushing that way. And I guess my outlook is, if I have it removed at my age, considering the stage it's in, it's hopefully within the prostate still. Going forward, if something pops up, something reoccurs, I can go to radiation. From what I understand, if you do the radiation, that rules out the surgery down the road, and then you get into ADT and a lot of other things, I guess.
Well,
that's
go ahead.
that's kind of what I'm looking, what people are thinking, not thinking. you know, they've been through this, I guess, and whatever.
Stuart, you're gonna say something?
Well, yeah, it's not accurate to say that if you have radiation, you can't then do surgery. But that's sort of putting the cart before the horse. What really the focus should your focus should be on, if you're being treated, which form of initial treatment is the one that's going to best address your situation and address your personal preferences, and you know, there's always opportunity down you know, if in fact there was to be some recurrence, there's plenty of options down the road that you shouldn't rule out radiation just because of that. Mark.
Okay,
I
I was
understand.
going.
I'm sorry, go ahead.
Okay, I was going to mention that, you know, the surgeons like to say, and I am a surgeon, by the way, like to say a chance to cut is a chance to cure. And patients, guys like to say, well, I just want to cut it out and get rid of all the cancer. But if that's the case, why do 30% of guys have, who have the surgery end up recurring in general? And the reason is that most of us probably have microscopic spread, regardless of what the path specimen shows, regardless of the MRI, regardless of the PET scan. And it's really our immune system that suppresses the growth of these cells that are outside. So one, to think that surgery just gets it all is just not the case. Then, and I wanted to be stronger what you said, Stuart, that with the newer radiation techniques, you have much more precise than the ones that were available when your surgeon trained. So they've reduced the margins. They can monitor for movement, and the treatment sends the beam in from anywhere from 3 to 15 to an infinite number of paths. So damage to surrounding tissues is far less. They're using a gel to space between the rectum and the prostate to cut down on side effects with it. And there was a recent study called the PROTECT study, and that initially was done to compare active surveillance, surgery, and radiation if the disease was confined to the prostate. And what they found in that study, again, it was early and it was older, but they found no difference in active surveillance was just as effective in that group. There was a follow-up study then that looked at years later to decide who required treatment for biochemical recurrence. And if you had cribriform pattern in the pathology and underwent surgery, you were 3 times more likely to need treatment at some future time. So just the idea to think that there's an advantage. And while it doesn't happen to everybody, about 50% of guys are still using some protection at 2 years after surgery. There can be pulmonary embolus, there can be infection. Wearing a catheter for 2 weeks is not always a friendly thing. And if there's an ED concern, that is more likely to happen immediately with surgery than it is with radiation, where it happens later. And there's a possibility that you could be dealing with incontinence for the next 30 years after surgery. It's rare, and there are means of taking care of it, but all the complications are more sudden and more severe in onset and more persistent after the surgery. So that's my 2 cents.
Jeff, has anybody mentioned or have you come across in your research the nomograms, the Memorial Sloan
No, I have not.
Kettering? Memorial Sloan Kettering has a nomogram that you would probably, it's not perfect, but it could also help you understand what the probabilities are of, if you were to choose surgery, what your likelihood is of not, what the chances are that you would not need any further treatment. David, could I impose on you to describe for Jeff the nomogram, since I know you're familiar with it?
Sure, Jeff, it's a online questionnaire in which you plug in all the basic numbers you just gave Stuart, your Gleason score, your tumor stage score, which would be like a T2A or something like that, and your age and so forth. Now, like you, Jeff, I also had a 4+3 with crib reform. And when I did the nomogram before treatment, what it said with a 4+3 is my chance of making it to 5 years without a recurrence was less than 50%, and my chance of making it 10 years without a recurrence was right around 30%. So the odds were not great with surgery. So that certainly pointed me in the direction of radiation. Also, something Dr. Marks said about crib reform, there in fact have been published research showing a much lower recurrence rate with radiation for someone with crib reform than if they were to do surgery. And lastly, for me, I was treated a year ago with a lot of radiation. I had external beam radiation plus brachytherapy. And yeah, for about 2 weeks afterward, urinating was unpleasant, hesitance and a little burning and that sort of thing. But all that cleared up. I'd say by 80% of it cleared up within 2 weeks. By 2 months, even little minor side effects were gone. I'm a year out. I honestly can't even tell I was treated in terms of urinary or rectal problems whatsoever.
Interesting. Interesting. Now,
Now,
and when you folks did this, were you, I'm 67. Were you older? Was
I
age a
was
factor
66.
in making the decision?
I was 66. I did it last year at age
Okay.
66.
All right. Why, I wonder then, do they, you research, they say, oh, well, if you do radiation, surgery is not an option afterwards, whereas if you
Well, first of all, Jeff,
do surgery, you can always have radiation as a backup.
I didn't want to do surgery. I also had a pre-existing condition that made me disinclined to do it, but I didn't want to do surgery then, and I don't want to do surgery in the future either. There are other ways to treat a recurrence post-radiation besides surgery. I wouldn't do surgery if I had a recurrence. There are multiple other ways to do it. You can even, in certain cases, re-radiate. Or you could do certain focal treatments. Now, the success rate of a treatment for recurrence isn't as good as it is for the primary treatment, but I can point to studies involving radiation, particularly radiation that had a focal boost, where the success rate at 10 years for high risk patients, and you're not even high risk, you're intermediate, was in the in 85 to 90% range for avoiding a recurrence. There was a Japanese study that just came out in 2024 that found that to be the case, and I can point to other ones as well. So I'm not trying to talk you into doing radiation. I'm just telling you that there's another side of the story, and that surgery, in my personal opinion, I wouldn't do in the past, and I wouldn't do it in the future either.
I'm not, believe me, I don't want to do any of this, but unfortunately, I got a little
Yeah.
situation I need to take care of, but I'm trying to get as educated as I can on all the different avenues or approaches.
Well, we definitely understand that, Jeff, because we've all been there.
Mhm.
So I personally had surgery and radiation and other treatment, but that's a whole different story. But
Jeff, go ahead. I'm
as
sorry.
David was saying, you've got intermediate, but you do have cribriform, so you're going to need some treatment. You don't need it tomorrow, but you need to like you said, gather all your information, get more information, and figure out what treatment path you want to take. So with that being said, what do you want to ask us? Anything further that we can help you with?
Well, I don't know. I'm trying to absorb everything now. I was kind of leaning towards surgery, and then, doing this. It's a big decision that's just a lot of information to absorb and weigh and see
Yeah.
which way to go.
It definitely is, and I tell people all the time. We've had discussions about treatment regret. You choose something and then later you think you regret what you did. And I tell people all the time, I don't have treatment regret because I've had all the treatments, but no, but you don't know what would have happened if you got the other treatment, right? So treatment regret is something you shouldn't even weigh on your decision, because that's putting the cart before the horse, and it's trying to look at an alternate reality of what would have happened if I took a different path. So don't worry about that, right? Gather your information and figure out what's best for you. It's gonna be a personal decision, right? But it should be weighed with all of the pertinent facts that you need. Not just a preference, but an educated decision, right?
Absolutely. But in the nomogram, how do you spell that? The GNOME?
So
NOMOGRAM.
I'll put a link to it.
NOMA. It's at Memorial Sloan Kettering
Okay.
website. Since you're on the phone, you can't see our chat box. Someone
right.
put the link in there for you. But if you want to email, if you do, you have email?
Yes,
If you want to email me, email me at info@ancan.org, I can provide you with that information.
Okay, absolutely.
Outside the group, we got a couple of people that want to ask you questions. Who raised their hand first?
David.
David.
Jeff, I guess my opinion, Jeff, is you haven't talked to enough doctors yet. Maybe Stuart or someone on the East Coast can suggest a good center of excellence to go to, as opposed to where you've been so far. I mean, I'm a little worried about, I'm not a fan of the kind of biopsy you got, for example, and that just makes me think, well, maybe you should go talk to somebody else. And I know in my own case, talking to just more than a couple of doctors was really helpful.
I would appreciate some referrals. The biopsy was not pleasant. I mean, to hear this thing snapping, you don't know how accurate is that.
Well, you got a blind random biopsy, which means they were literally shooting in the dark. Now, in your case, they happened to hit 3 samples of 4 + 3, which is significant. Your MRI is odd in the fact that it didn't return anything when they looked at it, which is not consistent with your biopsy. Now, your regular urologist was not at Tallwood. You went to Tallwood for the surgical consult.
Yes, he referred me. It's all part of Hartford Healthcare.
Yeah.
Hartford Healthcare umbrella.
I'm familiar My regular urologist and the urologist who originally started my diagnosis is also at Tallwood. Tallwood is a very good practice. In terms of, I guess you're closer to New Haven than you are to Boston. Am I right on the mileage there?
Yes, absolutely.
Okay. Yale New Haven is a center of excellence, and that would be one place to go to get another opinion on your whole case, both in terms of, well, they're going to look at they're going to be looking at the biopsy anyway, so you'll have that, but you could talk to a doctor there and they can sort of hear what they have to say in terms of how things have stacked up so far and what their recommendations would be.
Any referrals at Yale New Haven or suggestions, recommendations for doctors?
I don't have one off the top of my head. Rick, do you?
Yeah, I can look, but one of our moderators who had surgery in your Hartford system goes there, and I would talk to him, but we have not had good luck with people who have been treated in that Hartford system. Jeff, to be honest.
Okay.
But I'll do a little bit of research and I'll come back on and see if I can give you a name. We can certainly give you a name of a radiation oncologist and a medical oncologist at Hartford. I don't know. I don't know if you have, if we have a urological oncologist. I'll have to look and see if I recognize a name or something like that. There's a couple of things I wanted to say. So since I have the mic, I'll go forward. First of all, when did you said you were diagnosed in June, late June, is that right?
My initial diagnosis was the on 3/1/3/12, and then they did a biopsy on 4/1 of this year.
Okay.
And then on
so that's
4/14,
okay. That's okay.
Yeah.
That's
April.
You have time. Okay. So that's important for you to recognize. You know, with a diagnosis of this nature, you have some time to work with it. As good as New Haven.
When you said,
Go ahead.
I'm sorry, but just one question I had is, when everybody's saying you have time, I try to quantify is 30,
so
60, 90, 120.
Well, I was first diagnosed back in the day in August. I was diagnosed in May, and that's when I first realized I had an issue, and I think I got my biopsies around August, and I was a stage 3, 4+4, and my doc told me I had until the end of the year to make a decision. So, if you like, on that basis, I'm going like 8 months from when I first learned, and my doctor's going all the way out until the end of the year. So I think that if you got that supposed 4+3 diagnosis middle to the end of June, I can't give you the medical advice, but if it were me, I wouldn't be too concerned about making a decision until, at least September 30th. So you that would be me. but you have to talk to your docs and you have to ask them. I'm not thrilled with the docs in the Hartford area based on other people who have been treated there. I think that New Haven would be a good place for you. I can certainly give you names right now of doctors in Boston, and I can give you names of doctors in New York City. And I can give you names at New Haven, but not a urological oncologist right now. I just need to do a little bit of checking. I would say that as good as New Haven is, that's not where I would have sent my slides. And we've had actually issues with that in the past. And your slides really need to go to one of the doctors that's in our second opinion, which you can't see now because you're on the phone, but namely either Dr. Epstien or Dr. Zhao or possibly Dr. McKinney in Cleveland, at Cleveland Clinic. But I wouldn't rely on what I get back from New Haven. The guys were being nice to you before. That's who's got to see your slides, and I think you can definitively rely on an opinion from one of those three.
Okay, and Dr. Epstein is located at?
Epstien is now in private practice in New York. If you go to it's all written out. If you go to, when you write to Bill, he'll send you the link to that, where all that information is. Dr. Zhao is at Mount Sinai. Dr. Epstien was at Hopkins about 4 years back. He's now in private practice. Zhao is at Mount Sinai in New York, and McKinney's at Cleveland Clinic in Cleveland. But
Okay.
you have to get your stuff back and then send it out to one of them.
And you're saying I should get that physically from Hartford Healthcare? The slides and the stuff, or have the request that they sent?
What I would first do is see if they've sent them out, because they said they were going to send them out. A lot of the times they don't do it. And if they haven't sent them out already, stop them from sending them to New Haven and send them to Epstien or Zhao. And they will know, they should know how to do that. If they don't know how to do that, you can help arrange that. You can have Dr. Epstien pull the slides. I forget how Dr. Zhao works, but we don't really have time right now to get into that detail, but we can help you with that.
Okay, that's good to know. Thank you.
And let me take a look, and if I can find a urologist, I'll send the link to Bill, and we will also. We'll let you know on the phone. But as you see, it's really much easier if you can, rather than call in, if you can come in through the computer, because there's a lot of information that flies around that you can be picking up right now.
I can try and log in. My only problem is the sound on my computer is not good.
Well, here's what you do, okay? Log in and keep your telephone going and shut the sound on your computer. And if you do that, we'll pin all of this so that you can see all these things when you log in. You click the little red push pin at the top, and this information, the information we want to give you, will be at the top of the screen. Perfect.
And if that somehow ends up not working out, please do email me at info@ancan.org, and I'll help you out with all of this.
Okay, let me see.
So is there anything else we can answer for you right now, Jeff? We do got a couple other guys.
No, I've got a lot to absorb.
All right.
And I appreciate all the information you've given me. I don't want to monopolize everybody's time as well.
Oh, that's what we're here for. That's why we let you go first. You were the new guy.
Let me see if I can get this.
All right,
Okay.
Stuart, who's
Yeah.
who's next on your list?
Brian is next.
That's what I thought.
So Brian, tell us what I
Okay.
know you've had your biopsy and you have all your information.
Yep.
Tell us what
Okay,
happened.
I'll give you just a little bit of history first, quickly. Had P problems in 2020, so it goes back a long ways. In 2025, I had an MRI. It was PIRADS 2, didn't show anything. October 25th, I had my aquablation, and the sample they pulled out, they found a 3+4, and the 4 was only 10%. And they also ran a decipher score on that. It was 0.91. They said they took a, anyways, it doesn't really matter, but I was thinking they said I had PNI. I had PNI. It was 3+4. They pulled out 20% of my prostate, 70% was tumor, and I only had PNI. The decipher score they did on that sample was 0.91. Okay. In May, I did another MRI, their fusion or their 3T. I did on a 3T machine. I did use contrast. They wouldn't do it without it. It was a PIRADS 2 again. That was May of 26. At that time, my PSA was hot at 6.3, probably at the high mark. And just last Wednesday, I had my transperineal biopsy that you guys talk about. It took me a long time to get it. It wasn't fusion guided because there was nothing to target. I had that done at the University of Washington through community care using the VA. So I got my results last Friday. I'll just try to read this here. I kind of put it in my own little notes. It was just a random 12 core. All 12 cores were positive. 8 of them, they kind of branched it off into 6 different cores. Basically it's 8 cores are 3+4, and 4 were 4+3. And it had all the bad stuff. Extraprostatic extension was present on 2 of the 3+4s and 2 of the 4+3s. The 4+3 was on the right anterior and the right posterior. The highest grade was 4%. It also said 30% cribiform, and it was large cribiform. I heard Rick talking about that the other night. Okay. It wasn't. Yeah, the percent of 4 was 30%. And I had cribiform large. I had EPE, which is extraprostatic extension. That was there. I don't know where. And I had IDC, intraductual carcinoma. I don't know where. Mm-hmm. Called Dr. Jonathan Epstien this morning. He answered the phone. To see if I can send my slides to him. I'm just still waiting for him to get back to me. I did call the University of Washington here, and they said, can't do it that way. They said he has to request them from the University of Washington. And I think Dr. Epstien was saying that to do it just the opposite. So I'm having a little challenge in that area. August 10th, I got an appointment with the radiation oncologist at the Seattle VA. He's a clinical assistant professor. He's affiliated with the UW, University of Washington, and he also works with Fred Hutch. So that's what I got. So all this time I'm thinking I got nothing, and now I found out I got all the bad stuff. So I'm kind of changed my life a little bit. Talked to my heart doctor the other day, because I got a new heart valve 3 years ago, aortic valve. So I went and saw him. I said, hey, I might have to do ADT. So he's aware of that. And I talked to my electrophysicist because I got permanent AFib. So I've been talking to all my doctors. That's kind of where I'm at. So I'm kind of I'm really overwhelmed with everything. So don't know. I guess I'm going to go talk to my what do you call them? The radiation oncologist on August 10th. So I don't know what they're going to say. We're just going to talk for 2 hours. And I don't know if I need a medical oncologist. I think maybe I need a cardio oncologist. So I don't know any. So that's it.
Yeah.
I didn't know if you guys wanted it. Dr. Mark or Rick wanted to, or anybody else. All that.
Rick, were you going to say something?
Well, I was going to let you guys go first. So why don't you, as moderators, respond, and then I'll what you don't cover, I'll chip in. I just want to give Brian, first of all, some comfort. We got your back. We'll take you through this. It's no different to what a lot of us face, like Bill and I. I was diagnosed stage 3. The problem is your expectations have been that you may not even have to do treatment. But if you have to do treatment, you'll do it, and you'll come out the other side, and you'll be fine. Yeah. But you got to allow yourself to be fine and not make yourself crazy in the interim. And that's a very, very important aspect. Is that Mrs. Bryan sitting next to you?
This is my girlfriend of 13 years, Susan. She
that'll do for Mrs. Bryan. 13 years makes you Mrs. Bryan. Susan, you know, you're the one with the hammer. You got to bang his head a few times, and you know, so he makes himself as crazy as he's making you.
I got the hammer out today. I agree with you, but he is malleable. He's
okay
and hard-headed, but he's
okay. Malleable sounds good. What are you gonna do? Sit on his head or something? I don't know, but yeah, but. Let the guys first of all kick you off, and then we'll give you some guidelines. And just again, remind me, how old are you, Brian?
66.
66.
Yeah,
okay,
66.
So I got it. And if you need the one thing I can tell you, which the guys might not know, and then I'll come in at the end. If you need a cardio oncologist, there is a lady at UW who's supposed to be very good. She's certainly lively. She's got a fancy Greek name, and I'll put her name in the chat window for you. And Mr. David in Portland is a big expert on the cardio oncologists in your area, so he can speak to that. But why don't we let Stuart and Bill go first and run the nomogram? Look, we already put that nomogram in the window, so you can run that nomogram. That's an important thing.
I did that, and I think you already gave me the lady Effie. She's a Andrika Pocolo, or I think you already gave me.
Yes. Yeah, you got, yeah.
Really good notes. I take really good notes.
Okay, so I don't have to go look for it in the chat window and put it in the chat window again?
No, I got it.
Okay. Okay. If you lose that paper, don't hesitate to call me. It's okay.
This is my job now, to figure this out. That's all I do.
Okay,
so,
okay.
And I got a decipher report, and I know I need to get the grid report. I'm not sure how that's going to work, but and I know Dr. Mark said he knew how to read those, but I don't know how to. So I'm going to work on that.
So they're sending.
I have the decipher report. I did not order the grid report yet.
No, but you have.
Has to order it.
Do you have the decipher score back from
yes.
the biopsy? Yes. And what is it?
They did it. They did that in October when they did my aquablation.
Right.
They took I have it 0.91.
Right, but are they going to send from from the 3+4s and the 4? They'd be sending it from the 4+3. Are they sending that?
Yeah, still, I don't think they need to. If he's 0.91 back then, you know, what are we going to find? What are we going to find out? He's 0.95.
No, it might not be 0.91.
Well, but if he was 0.91 back then, and it's likely hasn't gotten worse. I think you have a pretty good idea. I mean, I don't know that it's necessary. If it were me, I wouldn't repeat this. Stuart might. I wouldn't repeat the decipher, but I would get that. I would get the grid report because there may be some good stuff in there.
Okay.
Oh, Brian, you've been around us long enough to know that, you do have some time. Your situation is a little bit unusual because we don't know how long some of this has been sitting there, but you do have some time. I think probably the most important thing that I hear, which may be obvious but is worth saying, is given all of your medical situations, it's really, really important that anybody that you talk to, whether it be the radiation oncologist, whether it be the surgeon, that everybody is briefed, that you make sure they're briefed on everything, that they're taking that into consideration, because otherwise you could start to be led in the wrong, or in an inappropriate direction.
So I'm thinking brachy there, or not brachy, but I'm thinking SBRT. I mean, I'm already thinking all these things in my head, SBRT. And,
okay, obviously radiation is an option, which means you probably should be thinking about getting a prostox test.
how do I do that again?
We can get you the link. You can,
Okay.
and remember that what that test is designed to do is tell you if you are at significant risk for significant side effects from SBRT.
Oh, okay.
So, since that's a very possible treatment direction for you, that would be a really important test to have info on before you get to making a decision.
How much time do I got? No, not a lot.
It's really hard to say. I'm not a doctor. I would say that, you should be pursuing the various conversations as, without wasting a lot of time with looking, so trying to, it's hard to put an exact date on it, but you should take enough time to make sure you talk and get clear information from all the appropriate doctors so that you have time to think about it and decide how, what makes you comfortable with the goal of moving towards a decision promptly.
So I'll go talk to the radiation oncologist, and do I need to make an appointment with the radiologist also, or not the urologist? Because I get all my care through the VA, unless it's and I can go through.
Well, if you're going to stay at the VA for your treatment, Brian, and I think it'll be hard for you to get community care because the VA probably provides most of what you want. If there's something that you want that we can justify that is not available at the VA, we can get you back to Hutch. So, for example, if you really feel you want to see a cardio-oncologist, which I doubt the Seattle VA has, we can go through the community care route to get you there. For a urological oncologist, I think it's going to be hard. At the same time, you should have your choice of urologic oncologists at the VA, and you want to make sure that if you're going to talk to a surgeon, you talk to the most experienced surgeon. And if you're going to speak to a rad-onc, you speak to an experienced rad-onc. Now, my guess is, I don't know for certain, but my guess is that there are going to be some UW practitioners who also work at the VA.
Yeah, they
So,
do.
for example, in San Francisco, a lot of the top radiation oncologists like Mac Roach also see people at the VA. So what we got to do is see if we can find someone. And if you give us the list of who's available to you, we can figure out if we know any of them.
Okay.
Do you need a medical oncologist at this point? Probably not. One thing you do need, if you haven't scheduled it yet, is a PSMA scan.
Right.
Yeah.
That's what I thought.
And that's what I would put at the top of your list based on the biopsy they did and the results they've given you, but pending what Dr. Epstien says. By the way, to go back to Dr. Epstien, he's happy to pull those slides.
Oh,
If
he
you
will?
call him up tomorrow and say, Dr. E, could you do me a favor and pull the slides? Because Hutch won't send them unless you pull them, he'll take care of it.
Okay, I'll do that. I'll do that.
Yeah.
Okay? We'll send him an email and he'll take care of it. You know how responsive he is. He's really good about that. And tell him AnCan says a big thank you too.
Oh, I already did. He answered the phone.
Okay.
We talked for 2 minutes and 24 seconds. I timed it.
Okay.
Yeah, I was in shock when he answered the phone. I almost dropped my phone. Is this doc? Is this? Anyways, we had a good talk.
Okay. So what you do want to do is get back to the VA and schedule that PSMA as soon as you can, because that's going to be really important.
Okay.
Get a second opinion on this biopsy, because that's going to be very important. And then take a big old deep breath and probably figure out your best uro-oncologist at Seattle VA and your best radiation oncologist and try and get to them.
Okay.
David, you have your hand up.
I'm just responding to Rick's suggestion of Portland resources. Are you open to some of that, or would you rather stick really close to home?
I'm open to anything that will work good.
Okay.
We don't care. She likes to go to Portland.
Well, let me give you a couple of names. Before I would even see a cardiologist or an oncocardiologist in Portland, I think the person I would most want to see for a one-time consultation is Dr. E. She's fantastic and can potentially help you sort.
Well, she can. Well, here's the thing. I hate sending people to Dr. E who are trying to make a radiation versus surgery decision.
Okay.
She is very, very good at it, but she is a medical oncologist, and we don't usually send our people to medical oncologists for that decision, right?
Okay.
If Brian is having trouble figuring out which way to go, yeah, we could get Dr. E involved later on, but I think it's not needed right now. That's what I would say. Now, God forbid we find that there's something outside of the prostate, because he has ECE and something might have gone out and something shows up on the PSMA. Yes, absolutely. I'd say that Brian could go down and see Dr. E, but it's going to cost him whatever she charges. I forget. We know, but whatever she charges for a private consult to get him straightened out, because she won't be covered. She will not be covered by the VA.
No, but he could use his Medicare coverage for that, and it probably would cost him about $35.
Okay.
But I hear what you're saying about the medical oncology aspect. Regarding cardio-oncologists, there are only two of them in Portland that I know of. One is Maros, M-A-R-O-S, Ferencik, F-E-R-E-N-C-I-K. He's at OHSU at the Beaverton campus. He's within his subspecialty. He's hot stuff, but his subspecialty is imaging, cardiac imaging. He was the former president of the Society of Cardiac Tomography, and His name is on a lot of papers and guidelines that the AHA puts out. The other one is Michael Layoun, Layoun. He's in a community practice at Providence. Of the two, I would go to Ferencik because Layoun is actually a protege of Ferencik. And even Layoun told me when he saw that I had seen Ferencik, he said, "Oh, you should definitely go to Ferencik." So that's what I did. Here's what I learned from both of them. They both said the same thing. I wrongly assumed that when you have prostate cancer and a cardiac issue, that would cause your oncologist and your cardiologist to jointly confer and decide on the best plan of action that would kill the cancer while safeguarding your heart. That is not how it's done. Not how it's done, at least by these two guys. And they both were pretty clear about this. No, they take a hands-on position on the oncology treatment, and they see their job as following up and helping with any sort of side effects that have cardiac implications. So it's not like Ferencik is going to call up your doctor who's deciding on which medication to give you or which procedure to give you and say, well, instead of that one, let's do this one. This is a much better one. No, he's going to just say, okay, this is your oncological treatment. Here's what I'm going to do to help offset that. At least that was what I was told. And my problem, cardiac wise, is different from yours. As you know, mine is more plaque related and yours is more electrical. So maybe it's different with your situation, but that's what I was told. Anyway, those are the only two in Portland I know of.
David, I appreciate that.
But wait a minute, where are you, Brian? You're in Seattle, right?
I'm in Seattle, and I'm in Seattle, and I'm connected.
Okay, so why are we talking about Portland? I mean, here's my problem. Here's the problem. We got a lot of people today, and we're happy to help you, but we're going down rabbit holes here.
Yeah.
Right.
We're good.
So let's stick to Seattle, where we know we've got a decent cardio oncologist at Hutch. We've already talked about that.
Yes. Okay. I'm going to work on that PSMA.
Okay.
Okay. Thank you, guys. I appreciate everything you guys do.
Okay, so let's run through the various updates. David, you're first.
This will take 2 minutes. I brought up last time some weird blood work that I had recently involving lymphocytes and monocytes and things of that sort. I met with Dr. E. She's not concerned. She said, yeah, they're abnormal, but they're not that abnormal. And it very well could be your body's still adapting and adjusting to the treatment that you went through. She's going to be testing me again every 3 months to monitor those and monitor the trends. So my concerns were, and she definitely didn't think I needed to see an immunologist or a hematologist. So that's where I'm at with that. And I feel better.
Good. That's good news. Okay. Moving next, JR. You there?
Yes, I'm here. I just wanted to follow up. I actually got the second opinion from Dr. Epstien. And I feel that he downgraded some of the numbers I had. And he put in the comment, the pattern 4 in this case lacks large critiform morphology. There's no PNI identified or the intraductal carcinoma not identified. The percentages were also brought down to the highest being a 5%, as in the other pathology report, it was 15%. So I'm pretty happy about that. There's nothing higher than 5% on it. And I am very glad I followed you guys' advice and did that.
Well, that's good news. Did Dr. Epstien offer an opinion as to whether he felt treatment was appropriate or whether AS was an option?
No, not yet. I think I sent them an email and requested to do a consultation with them.
I would be curious to hear what he says, because you still have, if I'm looking at my notes, 6, 7, 8, 9, you had like 11 positive
yeah.
cores, right?
Yes,
He
but
did-
now there's 4 that are 3+3, and only 6 that are 3+4.
Okay, well, the question of what you want to explore, whether it's with Dr. Epstien or someone else carrying along his report,
Mm-hmm.
is the opinion of whether 6 3+4s, even with very low percentage of 4s, warrants treatment.
Yes.
Yeah,
And I
because
did, yeah. And
Right,
I
so-
also transferred my care to Fred Hutch. The VA already sent me referrals to one of them. I'm just waiting for the other one in case I have to go to treatment, but I think I'm gonna have to try to stay a little bit more on active surveillance.
I think that, that's really, you're at that, your core question is treat, or can you stick with AS? That's
Yeah.
the good news is they've taken any of the potential nasty. He's taken a bunch of the nasty stuff off the board. So,
Yes.
any other questions?
Nope, that is all I have.
Okay.
JR, where did you get your biopsy read?
Oh, the first time or this one?
Yeah, the first time.
Oh, the first time it was here through locally and close by Seattle. It was actually in Gig Harbor. By
The reason we're asking is for Jeff's benefit. So Jeff, you knew Jeff. So Jeff, you can hear that a biopsy can come back with a very different reading when a guy who is one of the best eyes in the world takes a look at it. And this is why we feel it's really important to get a second opinion, because we can trust that eye and we don't want to see people going through unnecessary treatment. So I'm just jumping in to pull your attention to that. It's so important.
Ignacio, did you say they saw no, Dr. Epstien saw no cribriform? Is that what you said?
I don't think you meant to ask me.
JR, you meant.
Oh, JR, I'm sorry. Is that what they said?
let me see here. No, there is pattern 4, but the percentages are very low, but there is no large cribriform.
Oh, that's fantastic. That's a big finding right there.
Yeah.
Okay, well, keep us updated. It sounds like you've got a clear path in terms of what you're trying to follow up on.
Yes, thank you.
Great. Ignacio, what's update?
Hey, thank you for the time. I'll try to be quick because I know there are other people. So it seems like since I've started down this journey that I get like a sequence of good news and bad news and good news and it's just a seesaw of competing news. Back in May, I had my MRI. All indicators were bad. In that the ADC had gone down. One of the PIRATS 4 was upgraded to PIRATS 5, and so then, so obviously that was bad news. So I had a biopsy, a perineal biopsy, and the results from that indicated, at least to me, that the news were good, because what was seen as suspicion of extracapsular extension on the MRI, per the biopsy, no extracapsular extension was seen. And all the cores that came back positive came back with 3+4 with very low 4, no crib reform. And in fact, I have 2 Pirates 5 lesions. The first one came back as not being cancer. It was entirely, benign, prostate tissue, which was, surprising in a good way. And the other Pirates 5 was 3+4 with 5% pattern 4. So the news, from the biopsy, in my interpretation, were actually quite good. And then I had the meeting to go over to the biopsy with my my PA, or as doctor's PA, and she said that that everything is still on the table. In other words, I can continue on active surveillance, but when I had the biopsy, I'm sorry, no, that's accurate. Sorry, let me start over. When I had the biopsy, the doctor said that on the ultrasound, she could also see suspicion of extracapsular extension on the ultrasound. So now both the MRI and the ultrasound during the biopsy indicate the possibility of ECE. However, the formal biopsy results say no ECE or no extra prostatic tumor seen. So basically, the current status is that I will be having a PSMA PET scan on August the 20th, and that's going to determine if I should pursue treatment or not. The question that I have for the team, though, is that the whole sequence of good news, bad news, good news, bad news, there is a part of me that says, let's just go have treatment, get it over with, and be done with it. And I would like to know if that's a valid feeling, or if I should hold on. I mean, to be going through an MRI every year, that's not too bad. The biopsy, that's not pleasant. I would prefer to not do that every year. So anyway, I wanted some opinions from the people out there.
Mark, you have your hand up?
Yes, I do. So I think one of the problems is we get a lot of information, and our medical teams have more and more information, tests that they can do and look at, that will push their decisions one way or another, their recommendations. Unfortunately, when we see this, we tend to look at one test and see, oh, that means something. Mm-hmm. And it really doesn't. We are not in a situation where we have a lot of absolutes. I mean, when we look at biopsies and you get a report back from a local hospital and it says you've got a high percentage of 4, or you have cribiform, and then you send it off to Dr. Epstien and find out that you don't. Mm-hmm. You're right that we get this news back and forth, but it's good to get into a mindset where we don't know. We're not looking at something. What you're calling bad news is really just looking at the direction in one direction or another. It's not an answer as to what it means for your health and your well-being. I think the most important thing is the PSMA PET, and say that shows bad news. I mean, 5 years ago, I went in and did my PET, and it showed I had disease outside, and I had to spend 6 months with some ADT and abiraterone, and did 5 treatments, and it's over and done with. PSA is still undetectable 5 years out. I'm back on testosterone therapy, and I actually think for me the experience was good. I got to meet you guys. I got to get involved in the community, and it's not bad news. I mean, the good thing is you have an opportunity that you're not doing this alone, that you're part of a team of people who've done it, and when shit happens with prostate cancer, what we don't think about is that the majority of the people who have trouble, and it is bad news, are the ones who show up with disease all over the place, with multiple metastasis and PSAs in the hundreds or thousands. But for us, this is primarily going to be over and done. And it's what's the easiest thing that we can do? And are we seeing the right people? And you've got all the people here to help you do that. So there shouldn't be bad news.
So, well, okay. What I meant by a bad news is, having to undergo treatment.
Okay. I wanted to doing annual biopsies, even every 2-year biopsies, should be less and less a factor. Out here in California, there's a company called Caris that's doing a liquid biopsies. There are other assays that are developing that within 2 or 3 years, I think we'll have much better ways of monitoring people with active surveillance. So it won't be the biopsy every year. It won't be the MRI. The problem is PSA is not 100%. There are 15 to 20% of people who can progress and the PSA doesn't go up. So we need better tools, but for the majority of us, it's not,
So let me add a couple other factors that play into the good news, the bad news. What I call the good news is that I had a second decipher test, and it came back low. It came back at 0.31, which is low, which is good news. The bad news, though, is that the PA told me that even if you have Gleason 3+3, if there's extracapsular extension, they would recommend treatment. So again, I'm like, okay, the decipher, who outweighs who?
So first of all, you were talking to the PA and not the doctor. Right. Second of all, despite the fact, I want to talk about people with, who are going through surgery, and 20 to 30% of them are going to have biochemical recurrence. And it wasn't that shit happens and all of a sudden they develop cancer again. Those microscopic cells were out there. And just because you have extracapsular extension, if it is close by that they could pick it up on a biopsy, then it's going to be treated with most of the stuff.
They could not on the biopsy. They could on the MRI and the ultrasound, but not on the biopsy itself.
And my situation was the exact opposite. I had 6 people look at the MRI and no one saw it. And on the PSMA PET, you can see it across the room. But you know what? The fact that I had disease outside the gland and I had to be on 2 medicines for ADT instead of 1, well, it isn't a big deal at this point.
Yeah.
I'm as annoying to my wife as I was before all this happened. And, you're getting these clues, but what one doctor tells you, what one test tells you shouldn't sway it. It's just, you got to weigh the scale, and the longer we go, the more stuff there is on those need to be balanced. But you know what to do. You get the information and you can make a decision. That's my 2 cents. So
right. Rick.
So a couple of things, Ignacio. To be honest, and this goes back as long as my experience with UCSF, the bloody PAs and the nurse practitioners there drive me nuts.
Mm.
And if you're going to have a discussion, which is a decision-making discussion,
Yes.
and I'll say this anywhere, but I'll particularly say it at UCSF. You don't want to have it with a PA, with a PA or a nurse practitioner. If you're just there for continued monitoring, you've been doing active surveillance and everything looks good and it's appointment, fine. But they don't know what they're talking about half the time. And I get people coming and say, "Oh, the PA was this, the PA was that." Let me tell you what I mean.
Yeah, I agree.
You don't have 3+3 you don't have extracapsular extension if you're truly a 3+3. You don't.
No, I'm a 3+4 with.
Okay, but she said to you, even if it's a 3+3 and you have extracapsular extension, well, hello, darling, you don't have extracapsular extension if it's a 3+3. If she said 3+4, I'd buy it. But they talk rubbish because they don't know, because they don't study in the way that we follow through. So the first thing I'd say is you're bad for allowing an important discussion like this to be had with somebody other than Dr. Chu or Dr. Carroll. If Dr. Carroll can't see you, Dr. Chu can see you, fine. But don't have these discussions with nurse practitioners or physician's assistants, please.
Okay. I'll take the blame for that. Maybe in my naivete, I took the fact that Dr. Carroll sent the PA to go over my biopsy as good news, because I thought,
okay, but then you write back and you say, Dr. Carroll, this is important for me. I don't want to see a PA on this appointment. Right?
No, you're absolutely right.
That's the first thing. Second thing, did you ask them if one of the needle samples was taken in the spot where they saw on the ultrasound and the MRI extracapsular extension?
Yes.
And what was the answer?
Yes.
And what did that core say?
Was there cancer?
It said no extra prostatic.
Okay, so there's the answer. What are we talking about here? Why are you making yourself crazy? It doesn't get clearer than that. If they put a needle through where they thought there was extracapsular extension and they pulled that core out and they read it and they didn't see it and Dr. Epstien doesn't see it, there's nothing there, because you can't get harder proof than putting a needle through that spot. Yeah. So what we've got to do, and this is what you've got to do, Ignacio, is you've got to move that from your mind. But you don't do that. You've got to accept there's nothing there, because we did everything to verify there was nothing there, and not sit there and say, well, but this said this and this said that, and maybe there is something there, and now I don't know what to do. No, gotcha. We don't have extracapsular extension because we stuck a needle through the spot where there was extracapsular extension and nothing showed when we looked at it. If you would have said to me, no, they couldn't get to that or something else, I'd say fine. But this is proof positive. I mean, Dr. Mark, what would you say about that?
I'd agree entirely. I mean, there's a tendency for us to want to look at and see the bad news and feel bad about it, but there is no bad news. And
there is no bad news.
And you know,
there is bad news. There is bad news. Argentina lost. Argentina lost. That's the bad news.
Well, I mean,
some of us, you don't seem too upset about it. Right?
I mean, if they had won that game, it would have been confusing when you look at how the two teams played. But the suspicion is that they should have won, but they didn't, and now we know. So we're not worrying about whether there were problems. We know who wins. That's the same thing. Analogy. You had a suspicion. This PA had a suspicion that things would be there, but you did a biopsy, and that showed that it wasn't. And
well, if Dr. Carroll ordered a PSMA PET scan, I'll still go through with it.
Well,
just
no,
for-
I think that's wise, because in my situation, they had none of that. They had none of that. And I felt, well, no biggie. And I was living in Atlanta, and I put off coming out to LA, which was the only place you could get a PET scan back then.
Mhm.
And I put it off because of COVID. It's not a factor. And then when I did the scan, found out it came out here, spent the 5 days with treatment. They tweaked the pattern a little bit because they had to get the seminal vesicles. I mean, it's not the end of the world if there's extracapsular extension. It just means, okay, we're probably going to treat it. But so far, you don't have any indication that there is. The fact that she has a suspicion, and then a biopsy showed that it wasn't that much of an issue, you don't have it.
Yeah.
Well, I'm glad to hear
You got to do the PSMA PET, and that's going to tell you whether there's concern for treatment. And if there is treatment, then you do the treatment.
Yep.
Well,
You know,
Ignacio, that's also the reason why you want to get in front of the doctor,
Yes.
because you are staring at, do I have to treat or can I continue on surveillance? And that,
Right.
that's a pretty serious conversation. And that's the one you want to make sure you have the doctor weighing in on.
100%. 100%. All right, clear now.
Okay.
Thank you all. Yeah, thank you all for your time. I appreciate
Okay,
the feedback.
sleep easier tonight, Mr. T. Okay, please.
I am retired as of 3 weeks ago, and I've been sleeping great.
Oh, that's
Good
good
job.
to know. Hey, Bill, make a note. He's retired. If we need any help anywhere, we got somebody we can ask.
There you go.
Okay.
There you go.
Okay.
I just typed his name into the notes.
Okay.
Steve, you're next up on the updates. You're muted, Steve.
Okay. Yeah, I just wanted to check back in with the group and let you know, first off, thank you for all the advice and support I've gotten over many months. I can't even recall the first time I visited this group, but I had a very successful radical prostatectomy 8 weeks ago. And thank you, Rick, for your recommendation of Dr. Egener at UCLA. He was excellent. The surgery went exactly as he said it would. It is stressful because the doctors tell you everything that can go wrong, and none of it did. So the recovery is going exactly as he said, and the biopsy of the prostate tissue was as good as one could hope. And so again, thank you, gentlemen. Thank you, Rick. Really appreciate this group and really appreciate you guys for being here. Thank you.
Oh, great. Happy.
Well, Steve, you kind of left us hanging. You said the biopsy of the tumor was as good as could be hoped, but you didn't tell us what it was.
Oh, okay. Happy to. So essentially 14 lymph nodes were taken out along with the prostate. All lymph nodes were negative for carcinoma. In the prostate itself, they identified main location with 3 + 4 = 7, grade group 2. Approximately, it says percentage of pattern 4, 20%. So that is a better outcome than the previous biopsy, which was a 4 + 3 on a fusion biopsy. So the actual examination of the tissue actually turned out to be better. And then everything else that they look at, extraprostatic extension, urinary bladder neck invasion, seminal vesicle invasion, lymphatic and vascular invasion, were all negative.
All right.
So it looks like everything was contained.
Fantastic.
Obviously, I had my first PSA follow-up blood work in 1 month, and I'll do a video appointment with Dr. Egener to discuss what that looks like. So, and I did take a look. He did say, and I did confirm with the Memorial Sloan Kettering nomogram, that given the results of the post prostatectomy biopsy, it is a 15% chance of a recurrence that would be need treated over the next 15 years. So as good as can be expected from.
And those are good numbers. And the reason I ask is because sometimes, sometimes you'll get I got my prostatectomy, and when they checked everything out that they took out, I had a higher Gleason score, and I had a higher percent chance of recurrence. And the surgeon told me the day after, the day of the surgery, when I couldn't think straight because I was under anesthesia for 6 hours, that she was pretty sure she didn't get it all.
Oh dear.
I mean, that was her comment, right? And mine was longer. Mine was going on over 11 years ago. So, and things like the PSMA and those they were like just in the beginning stages of testing them, let alone them being FDA approved or anything, or insurance coverage. So, and I did have a recurrence, but mine was immediate. So I didn't wait. My recurrence didn't wait, I should say.
Sure.
Yeah, my PSA was detectable right my first PSA test after surgery. So to get a result like that from the surgery is excellent. So, but it's important to note what they get after the surgery as well as prior to the surgery, because those can be key indicators of what you got. Looking down the road, I think you got a really good prognosis. So,
Right.
Rick's got his hand up.
Rick.
I just wanted to ask Steve, how was your overall experience with UCLA and also with Dr. Egner?
Dr. Egner was excellent. We went out to UCLA and consulted with him before the surgery. Went over everything that one would go over just as a consult, and he agreed with all the previous surgeons and radiation oncologists that given the huge size of my prostate, it was over 100 cc's, and my urinary outlet restriction, that surgery was the best course of action. I was going to have surgery in order to even have radiation, either a TURP or a HOLUP or something. And then the radiation was going to be at least 35 sessions, depending on the location, 35 to 40 sessions. So that just, anyway, Dr. Eggener, along with everyone else, recommended the surgery. So, and the experience with the staff at UCLA, both in the urology department and the surgical hospital, were excellent. And my only complaint, I'll have to write him about this since he is now the new head of their urology department, is their pre-surgery paperwork is a mess. It contradicts itself. You don't know what to do.
Oh, yeah.
The post-surgery paperwork was a mess. It contradicts itself. I didn't know what I was allowed to do because I was giving paperwork with contradictory things. Oh, you can do this in a week. Oh, you can't do that for 6 weeks. I finally had to message him.
Please feed that back to him. I mean, I've had issues even with my own experience where I've had surgery where the paperwork has been just rubbish. And I'm one of these people. I'm not a lawyer, but I'm one of these people who does read paperwork from my training. And I think he'll be super grateful if you give him that feedback. He'll be he really will. How are you doing with your ED and your incontinence issues?
Right. So the continence was minor after the catheter came out, and now at eight weeks it's almost non-existent. I'm still keeping a pad in my underwear, but there will be times during exercise or bending over to pick something up where I will feel the very minor amount of drops, but very minor. That's it. I was I have not been able to urinate normally for at least 4 years. I was on Flomax for a number of years to deal with it. Now having normal urination is a nice benefit of this surgery. So, yeah, and as Dr. Eggener said, there was going to be ED for sure. He didn't think he could spare all the nerves given the location of the main lesion. So, yeah, I'm going to have to follow up with him when I talk to him about what the follow-up options are with regard to that. So,
did they take both nerves, or did they only take one nerve?
As Bill said, when they're talking to you out when you come out that day after surgery, I would hardly remember any of it. So I will follow up with him. Yeah.
Here's what you need to do, and you can do this maybe even from the portal.
Mm-hmm.
Go get a copy of your surgery report. You need your surgery report, and you need the post-pathology report.
Mm-hmm.
Both of those should be available to you, and you can sit down and read them. You can ask us questions at the next meeting, and we can help you understand them, and that will answer a lot of the questions for you.
Great. Love that. Thank you.
And you need that in your files anyway. God forbid you have anything comes back, you want to have those in your file.
Got it. Yeah, I just realized I hadn't printed out the biopsy. I only read it, so I did print that out for this meeting. But I did not print off the surgical notes. So
great. Okay, well, we're so far so good. We're keeping our fingers crossed. Yes. We hope this continues. And like we always say, the information you get here is priceless. So just remember that next time we ask for money, okay?
I haven't forgotten you guys, Rick.
Okay, thank you.
Okay, Henry.
Yes.
How are we doing?
So I'm okay. Yeah. So last meeting was my first, so I got a little bit of homework from the group, specifically Rick. First one was I need to get the second opinion from Epstien. I've been dealing with my doctor's office at City of Hope for 10 days trying to get that out to him. Now I'm going to give him a call, get him to take that directly based on what you guys told me tonight. Just been a lot of back and forth. The nurses have no idea what they're supposed to do. Second was a germline test. I didn't remember at the time, but I did have a germline test last year through an organization called what's it called? Prostatecancer.org.
Yes.
Yeah. Right. So I had forgotten all about it and pulled that up, and it was clean. They didn't find anything in that report.
Excellent.
But before I had found that, I had already scheduled a lab test for a new one, so I'm getting a second one anyway. And the third item was getting an expert to help me with the grid report. My urologist said he doesn't know how to read them, so he gave me a referral who was supposed to call me. I've been waiting for a week to get that call. So I knew that was probably going to happen in advance. I scheduled with the UCI medical oncologist to see if he could go over with me. So I had that scheduled for Thursday. And because I had the score of the 94. So that was the big kind of change for me in terms of what was going on and what that meant for treatment. I guess I'm going to have to, in my mind, I'm going to have to decide after that meeting Thursday with the oncologist is, okay, he explains to me what all these things mean, and it's a bad score, so I'm going to have to decide, on treatment, I guess. I'm not very comfortable with active surveillance on that kind of score.
Well, also, let's see what Dr. Epstien comes back with.
That's right. Yeah, I still got to get that too.
Yeah. And we can help you out with that grid report because we've got somebody here who can read them. And I really should learn how to read them. I haven't done it. I've been lazy, but we've got a couple of people here, so we can help you out. But when you meet with the medical oncologist, ask him whether he's seeing any of the what we call the bad boy somatic mutations.
Yeah, I saw that page.
Right, and we want to know: did they see P10? Did they see TP53? Did they see RB1? Did they see I forget? Did they see an SPOP? SPOP's really not so bad, but it might be. There's a couple of others, but that's really what we want to know: is are there any of those nasty mutations that they're basing that 0.94 on?
Yeah, I did look at it. Those the names you mentioned don't come. I don't recall exactly. There were like 3 or 4 that were very high in the 90s on that page. I didn't know I had the grid report, but I got a very bad copy. It's scanned and very blurry, so I didn't have a good one to read. But
well, that's down to your urologist, because he's got a good copy. Because
another thing
Decipher gave him a good copy.
So I was high in P10 loss. It says status deleted. I don't know what that means.
Okay, so that would make sense, that if you're showing a mutation in P10, that's why. Now that's good news and bad news. The good news is that just in the last month, we have a new drug approved that addresses P10. God forbid you ever have a mutation that shows P10. It's called TrueCap. The commercial name is TrueCap. TRUQAP, and the generic name's gone out of my head for the second. I'm lucky I can remember the commercial name, so that's good. The bad news is that you do have, which is exactly what we were looking for. And I think that if there is a and again, you talk to the medical oncologist about it, but if there is a suspicion that you're capiversitive, I should remember that, capiversitive. If there's a suspicion that you're making P10, it probably is another reason why you need to get treatment, Henry.
Yeah. I also had a 95% on KROS.
Oh, that's interesting, because we don't see a lot of RAS in prostate cancer, but it does occur, and we've seen it before. Interestingly enough, there's a huge amount going on with RAS. You might have heard or read about this new drug for pancreatic cancer that's gotten a huge amount of publicity recently. Well, that is Daraxonrasib, I think it's called. That is a RAS drug. There's no evidence that it would work in prostate cancer, but that's largely because RAS just doesn't. We don't see a lot of RAS. Maybe 1-2% is what I'm guessing. But all of those things are really important. And that's why with RAS and P10, that's why we're seeing that high score. What else you got there?
I got a high score on ERCC1.
I don't know a lot about ERCC1, but I know it's there.
Last one is RT sensitivity. It says status resistance.
Don't know about RT sensitivity?
Yeah.
Okay, so I'm wondering if that means radiotherapy. And I don't know how they're measuring it. It might be something like what they measure in Prostox. But what that tells me is that, and again, drill down on that with your doc, but it means that if you were to choose radiation, you should definitely get a Prostox test. Ask him if that's something that you can follow up with a Prostox test, because it might indicate that you're not a good candidate for radiation, and so you might be looking at surgery.
Right, that was my next question. Is there a lot of these markers can drive you to which type of treatment, right? Radiation or surgery?
I personally don't know anything about P10 or RAS pointing towards surgery or radiation, but that doesn't mean it's not there. We'd have to, you know, it would have to be investigated. You'd have to investigate it. That RT sensitivity, I suspect, is something along the lines of what Dr. Wiedenhouse looks at with a Prostox test, and probably suggests that you should get a Prostox test, which is just a mouth swab.
Okay.
And we have webinars on the website. We've got 2 webinars on Prostox on the website. You can listen to Dr. Wiedenhouse herself talking about it. She's at UCLA. But I don't know anything about, I mean, there are certain mutations I am aware of that mean you might be more sensitive to radiation. They're normally HRR mutations, which those 2 are not. You didn't see any BRCA didn't get mentioned anywhere, or ATM or something like anything.
BRCA's not on the. BRCA's not on there. That was on the germline test.
Oh, are you? Oh, yes, it's on the germline, but you're not BRCA positive.
No, I came clear on the germline test.
Right. No, I mean, but it's something they would have looked at, and if they saw it, it would have been featured just like they're featuring P10 and RAS.
Okay. And right now, my urologist is at City of Hope. He's done over 5,000 prostatectomies. Is that enough for me to consider him as my go-to guy, or should I? Because UCLA, UCLA is like really. 3 hours back and forth for me.
Yeah, no, you're fine. You're fine. I mean, well, wait a minute. Are we talking about City of Hope Duarte, or are we talking about City of Hope in Irvine?
Irvine. I have a Dr. Yoshida.
What's his last name?
Yoshida.
Sort of know of him, but I can't say I really know of him. So, but I would say he's probably good. But really, are you leaning towards surgery or radiation?
No, initially, when I first started researching, yes. But after listening to the group about radiation, I feel a lot more comfortable going with radiation. I'm really undecided at this point still.
Henry, quick question. That RT sensitivity, was it high or low?
It says resistant as status. It was 0.74 tumor score, 66% population rank.
Okay, that is what, from what I'm reading, that is what Rick suspected it is. It is an indicator about radiation responsivity, and resistant suggests that it.
Yeah, and these are grouped. I'm not. They're grouped as DNA repair tumor suppression is the group name, and the ERCC1 is in the same group with the high score of the ERCC1.
Yeah.
So
I do know something about ERCC1, but I can't remember what it is right now. Go ahead, Bill.
Yeah, I was going to say, as Rick suggested, the Prostox test would probably be a good idea then, if what Stuart read is indicating that you may have that sensitivity to radiation. or resistance. I don't know the actual phrase, right?
Yeah. So yeah, I'll have to. I guess that'll be a big decider on Thursday when I get this information.
There is I'm trying to remember what his name is. Hold on a minute and I will look it up. There is a good radiation oncologist in Irvine, but I can't remember if he's at City of Hope or if he's at UC Irvine. Just give me a second and I'll look him up.
I spoke with a Dr. Wang at City of Hope, WENG.
No, that's not the name I'm thinking of. The name I'm thinking of is Percy Lee. And Percy Lee, I think, is at City of Hope, and that's the guy you want to see.
Okay.
All right, I think I've got him bookmarked. And he's really good. Yes, Percy Lee, City of Hope. And hold on a minute, and I will put his. I'm putting it in his thing right now. Percy Lee, that's the guy you want to see. And we have very good reports on him from a bunch of people for a long time, and we have people who have seen him. And he's your man if you want to get I want to make sure I send this to everybody. There you go. There's Percy Lee. And I think Yoshida is good. I've heard of him. I've heard of him before.
And in the last meeting 2 weeks ago, there was a mention about Linac, MR Linac.
Yeah.
I'm not sure if City of Hope has that.
They do. And Percy Lee's the guy who does it there.
Okay, great. I'm in the right place then. Thank you.
All right.
Okay, great. Real quick, Jeff, did you get that phone number that I sent to you? Yes? You're on mute. I can't hear you. Okay, good. Okay, so Albert, we're to you. Give us the good news.
Yeah, I am. Thank you, and I'm going for my planning session with Dr. Kishan the 31st of August, and then they say within about 7 days there'll be treatment, and he is offered, and I have decided to accept to be in 2 different clinical trials. One is called Manticore and the other is Vortex. And the Manticore is to test the efficacy of adaptive radiotherapy, where they replan before each of the 5 SBRT sessions with MR Linac. And the Vortex study is for vascular sparing to hopefully help prevent or lessen chances of ED from the radiation. So the Manticore is, I will know which arm I'm put in, whether I get adaptive or not. And the Vortex, it's blind, so you don't know until a year or 2 later if you have the vascular sparing, as they call it, or not. The Manticore has a risk listed of, if you do get in the adaptive arm, maybe since they're replanning in an hour or less each of the 5 sessions, maybe it would affect it in some negative way they don't know about. And the Vortex, the vascular sparing, has the risk of perhaps less effect on the cancer because they're reducing some radiation to that area of the gland in an effort to spare the vascular system just below the gland, I believe it is. So I don't know. It sounds like, why not? Do both. And I'm kind of like, the adaptive sounds really good to me. I brought this up in the group before, and I forgot, but I believe someone said, what difference does it make? Well, there's some centers that are doing adaptive as a matter of course. And I talked to Dr. Kishan about it, and his opinion was, well, UCLA is the best at MR Lineac, and we're going to do just as well, whether you get adaptive or not, just as well, if not better, than if you went somewhere else and got adaptive. So I'm just hanging my hat on that. And I still have all the doubts I've had since December that y'all have tried to help me with. And I'm just like, have to push forward. So I would like to ask Greg about, did they do adaptive at Stanford, I believe is where he had MR Lineac. And I don't know if anybody else can weigh in on any experience or anything they've heard about adaptive radiotherapy, or if I should even bring that up.
I think the important thing to take away from this is you've decided to go to that appointment and get the treatment, right? So
Yep. And the idea is, it's like, okay, well, yeah. So even if somebody else does do adaptive, I called Nagar, and they're like, well, you can get an appointment and ask him. We don't know for sure, blah, blah, blah. I called Stanford, and it's like, I don't know. But I'm like, just like, I'll go around and around. Like Rick has said, I'll find any reason to not go forward. So
yeah, just keep the August 31st appointment and go forward.
Yeah, just stay the course. Stay the course, right?
I mean, and I don't know if Greg had an experience with the adaptive or not. I don't believe. Did you, Greg?
Can I ask you? Yeah, can I ask you what do you? I'm sorry, I don't even know what adaptive means. Other than I had another friend who you guys may know, Steve, and he went to Stanford and then he went down to he ended up having ICRT down at UCLA, but he was interested, if I understand you correctly, adaptive, like getting more beam, if you will, or more treatment or more radiation on his actual lesion itself. And I remember him kind of mentioning that to he said he asked Boyansky up at Stanford, and I ended up asking Boyansky the same thing, and Boyansky says, no, we don't wash windows either. He didn't actually say that, but what he said was, no, we don't do anything funny business, anything different. We just take care of the whole thing. So was his answer to me about my limited experience, if that's what you're meaning about adaptive.
Well, adaptive was actually replanning. You do the planning session a few days before treatment, and then adaptive radiotherapy is where they spend a half an hour to an hour before each of the 5 sessions, replanning it slightly, tweaking it for your anatomy of the day. But on that question about Steve, did he end up going to Dr. Kishan at UCLA because Dr. Kishan would boost to the lesions?
I think that may have been one of the reasons. I'm not sure if he's on today, but
he did go to UCLA with Dr. Kishan. I believe he opted out of the trial.
Okay.
Just went with the straight treatment.
Right. Did he give a reason for that?
I think it had to do with his specific case on where his lesions were and what they could or couldn't do.
Okay.
Anyway.
Well, and
but
then
I was under the impression that doing it Lineac was adaptive. I mean, by virtue of it being LINAC. So I'm not.
Well,
Well,
and I even asked that of Kishan, and he said, yes, some people call it adaptive because it does it does tracking, real life tracking during treatment, and therefore it's adapting to the conditions that
Right.
it's seeing. But I couldn't quite get, okay, well, how is that different than, how is adaptive planning different than the beam adapting in real time to what it's seeing? And I didn't get a real clear answer on that, but apparently there's some difference to it.
well, there is a difference. The adaptive, in the sense of what Greg was referring to, is that it's the MRI portion is allowing them to keep tabs on what's changing if things move, and adapt in the sense of turning off the beam if it's out of target. The type of adaptive you're talking about is, they say this area of the prostate is going to get a different amount of treatment than another area, and so they're modifying the amount of treatment in different based on the planning that they're doing. So, but let Dr. Kishan do his thing. As he
Yeah,
says, he's one of the best.
right.
And so you're in good hands. Positive, bravos to you for also participating in the studies, in terms of the trials, which will give them more information, which can make things better for other people.
Right.
And the other thing that I think you get out of being in a trial is you probably get slightly better attention from the doctor's office. That's been my experience.
Yeah, I remember you saying that. That was a factor for me in making the decision, and I appreciate that. I guess the last thing that, I still am having a hard time putting to bed is with the large cribriform, is like, am I doing enough? For a long time, I thought I need to do combined therapy like David did, brachy plus beam. But Kishan said in one of his videos, it's my opinion, it's not been proven, but that it was his opinion that, and strong belief that what he does, I don't know if it's specific to MR LINAC or SBRT, how he does it versus how other people do it, but that it could be equivalent to a boost of some sort that maybe brachy would provide. So I don't really want to do brachy. I just hope this is enough. So I don't know.
Again,
Sorry to jump in. I believe Steve did have a little boost on one side, like 5% or something. I think I do recall him saying something
Oh,
about
Steve
that.
said that.
Yeah, I
Yeah.
believe. No, don't take my word for it. And then
Okay.
also, I thought he did take part in some some study as well, or some. I'm not sure which one you're talking to and which one he's talking to, but he did
I
say he
think
signed up for something.
Yeah, Greg, I think he signed up for Vortex.
As
Okay.
opposed to,
I think he signed up for the Vortex trial.
okay. Yeah, you know better than I. Okay. Yeah.
Well, does anybody have an opinion on whether it's smart to do adaptive or not? If it's offered?
We're not the experts.
Yeah.
The
Okay.
expert is Kishan.
Okay.
And if Dr. Kishan tells you it doesn't matter, Albert. It doesn't.
Okay.
Because what are you going to do? If we say no, you got to do the adaptive. And you go back and you say, Dr. the boys in the group said, I got to do adaptive. Dr. Kishan's going to say, what do they know?
Right.
So, I know that Steve looked at it and he weighed it up one way or the other, but don't hang on to every little thing and drive yourself nuts on it. You've got one of the best radiation oncologists in the world, probably the best when it comes to MR Lineac.
Right.
And he's not going to lead you wrong. And if he says, don't worry, if you get the adaptive, we'll do this. But if you don't get the adaptive, you're better than anywhere else because we do it already.
Right.
You can rely on that. So don't be asking us because we don't know.
Yeah.
No, we only know what we hear from you guys. And so I think you're going to do just fine. I'm delighted you're getting the treatment. Did anybody tell you about the UCLA hotel?
Yeah, I've already made a reservation.
Great.
Yeah.
Great.
Yeah, Steve
Looks
really
really
liked that.
good. It looks
Yeah,
really
Steve was
good.
happy with it.
Yeah.
That's where Steve stayed.
Yeah,
And he really enjoyed
one
it.
of our board members is going to be staying there next week. He should have been getting his trial. He was in a trial for recurrence there, and it should have been today, but he finished up with a kidney stone and a stent yesterday morning, so he's had to put his treatment off for a week, but he's rescheduled for next week, and he's going to be staying there. So you're doing great and good for you. I'm proud of you, Albert.
Thank you, thank you, thank you. And thanks for sticking with me, everybody, all this time. That's the Tiverton at UCLA. That's the, yeah. Yeah. Okay. Well, great. Well, I'm going to follow through. I'm going to do it. So yay for me and yay for you. Thank you, everyone. Yeah.
All right.
Good for you, Albert. I think we're set unless anybody has anything else. Going once, going twice.
No, but I will tell